Ladies and gentlemen, please welcome to the stage AMCHP Chief Executive Officer, Jonathan Webb.
Good morning, AMCHP. I know it's the last day. We can do better than that. Good morning, AMCHP. Thank you. You guys should be used to it by now. I think you know what I'm going to ask you to do. With a twist, instead of turning to your neighbor and giving him a high five, find someone at a different table and give them a high five. So, on the first day, I mentioned to you that a quote that I really liked, that I heard a lot and really like to use, was if you want to go far, fast, you want to go someplace fast, go alone. If you want to go someplace far, go together. And I meant that for us as a collective MCH ecosystem, but it also starts at home. And I've heard really great things from folks. Thank you for the feedback that this conference feels different. It feels exciting. They really enjoyed it. And that's not just me. There's a team behind us. There's a team that works alongside us that makes this happen. So I'm going to invite all of the AMCHP staffers in the room to please stand because they worked on this for almost a year. So please stand. And stay standing for a second. Stay standing for a second because I'm going to ask us to extend the high five to the nearest AMCHP team member. I also did not want to lose the opportunity because part of our extended AMCHP family making this conference a success is our friends from conference managers. They're the ones who make sure we have this great location, everyone's rooms are right, checkouts are run, food is where it's supposed to be. They're the ones who really make sure, work alongside us to make sure all the I's are dotted and T's are crossed. So I love to ask our friends from conference managers to please stand. They're a little shy, but please stand and be acknowledged. And if you're close to them, please give them a high five. So over the last couple of days, you've had a chance to hopefully hear you feel like you've heard some really good sessions. One of the things we really tried to do is make sure that we're bringing different perspectives to the stage, we're bringing different ideas to the stage, and we're providing you with new insight and information. So hopefully you found it to be beneficial, informative, and enjoyable. We're going to keep that theme going today. We've got an exciting opportunity first to recognize some of our best practice award winners. But then we have a really exciting panel that's going to talk to us about substance use disorder and mental health, the intersection, and some of the strategies and approaches to engaging some of those communities that aren't always engaged in the process. So I'm really looking forward to this discussion. I hope you'll find it informative. And at this point, I would like to bring Michelle Hoffman, who is the chair of our Best Practices Committee, to the stage to get the process rolling and acknowledge those Best Practice Awards winners. Thank you, AMCHP, and Michelle Hoffman, please come to the stage.
Oh my gosh, that is so bright. Good morning, everyone. I'm Michelle Hoffman. I'm the chair of AMCHP's Best Practices Committee. The Best Practices Committee helps to identify, review, and disseminate effective MCH practices from across the country. Today, it is my great pleasure to recognize several colleagues whose work has made a positive impact in their community and in the field of MCH. Each year, in the fall and the spring, AMCHP's Best Practices Committee reviews submissions and selects practices for inclusion in AMCHP's Innovation Station database, which is a growing online repository of what's working well in MCH. The committee scores practice submissions on a continuum from cutting-edge practices, which have a perceived benefit to MCH populations, emerging practices which are based in public health theory or guidelines, promising practices which have strong evaluation data to demonstrate their effectiveness, and lastly, best practices which have been peer-reviewed, extensively evaluated, and replicated in a variety of settings. This year, we received 21 practice submissions. The 3 promising and best practices that I will now recognize received the highest scores overall. These practices demonstrated exceptional rigor, careful evaluation, and positive impact on MCH populations. The first award is a Promising Practice Award, which goes to the Rhode Island Department of Health Internship Program for Youth with Special Healthcare Needs in Region 1. The Rhode Island Department of Health Internship Program for Youth with Special Healthcare Needs addresses the successful transition of youth with special healthcare needs to all aspects of adulthood, specifically focusing on transition to employment. The program places transition-age students enrolled in the state's regional transition academies and school transition programs into office-based and entry-level internships throughout the Rhode Island Department of Health. Since 2011, the Rhode Island Department of Health Internship Program's aim has been to address self-determination and to give a population of youth that is nationally considered to be vulnerable a chance to gain skills through a real work experience. 2 years ago, RIDO, just the Rhode Island Department of Health, the RIDO internship program for youth with special needs was accepted to Innovation Station as a cutting-edge practice. And today, they're being awarded for the highest scoring promising practice that we received this year. We would like to commend Rhode Island for their hard work and continued dedication towards improving outcomes. Accepting for the program is Carmen Butcher, Principal Community Program Liaison from the Office of Special Needs Health Equity Institute, the Rhode Island Department of Health Program Development in Providence, Rhode Island. And so, Carmen, can you come on up? Our next award is our first Best Practice Award, which goes to Innovative Approaches, Community Systems Building Grants for Children and Youth with Special Healthcare Needs program in Region 4. The purpose of the Innovative Approaches initiative is threefold. Number 1, to thoroughly examine the community systems of care for CYSHCN. Number 2, to facilitate community identification of sustainable systems changes and promising practices. And number 3, to coordinate the implementation of these practices with agencies, providers, and families in the community. Since 2010, targeted efforts, including continuous quality improvement efforts to both build capacity and to implement change strategies, have resulted in service delivery systems improvements, which over the long term have led to meaningful improvements in the lives of children and youth with special health care needs and their families in North Carolina. 2 years ago, Innovative Approaches received an Emerging Practice Award at the AMCHP 2017 conference. Today, we are thrilled to award them a Best Practices Award and commend them for continuing to improve and expand their work. Accepting for the program, Heidi Austin, Director of the North Carolina Innovative Approaches Initiative, Division of Public Health, Children and Youth Branch at the North Carolina Department of Health and Human Services in Raleigh, North Carolina. So both of these award winners have demonstrated how practices can move along the continuum from cutting edge to the best category. Through Innovation Station submission and review, technical assistance from our MCH partners, and resources such as our replication project funding, we really hope that others will consider entering and moving along the continuum as well. Our next practice award was a new submission this year, PONO Choices in Region 9. PONO Choices is a sexual health curriculum developed by a collaborative team of diverse experts residing in the state of Hawaii and the continental U.S. The curriculum addresses the need for comprehensive, medically accurate, and culturally relevant teen pregnancy and STI prevention for middle school youth in Hawaii and the Pacific. PONO, as defined in this curriculum, is to act in ways that will result in bringing harmony to yourself, friends, family, and community. The curriculum is significant because currently there's no other current state-approved curriculum that explicitly incorporates the unique values and perspectives of the Hawaiian host culture. PONO Choices is being used by public school educators across the state in all 4 counties and has demonstrated increases in student knowledge, attitudes, and skills related to sexual health. Accepting for the program, Tammy Tom, faculty member at the University of Hawaii at Manoa in Honolulu, Hawaii. Thank you to our award winners and to all who submitted their practices to Innovation Station. By sharing and replicating effective MCH practices such as these, we can work together to achieve our goals of improving maternal and child health outcomes. I also want to remind you that we are always seeking new practices to review and include in our Innovation Station database, as well as new members to join our Best Practices Committee. You can visit the AMCHP website at amchp.org to learn more about these opportunities or visit our Best Practices table across from the registration desk. Congratulations again to our award winners, and thank you for sharing your great work with the MCH community. We highly encourage you to join our award winners in the exhibit hall at the AMCHP table immediately following the plenary this morning and to learn more about their work and ask any questions that you may have. Thank you.
Ladies and gentlemen, please welcome to the stage AMCHP President Cate Wilcox.
Well, good morning, everyone. I'm Cate Wilcox. I'm the Oregon Title V Director, and I'm humbled and honored to now be your new board chair, board president. I've never been a president before, so this is quite exciting. Today we're going to be honoring several of our maternal and child health leaders and those who have provided a lot of excellence to our field. But I'd like to take a moment and honor you. I think we all have heard the saying that there is strength in the collective, and that strength comes from its individual members. And individual members draw on the strength of the collective or the team and the group to be able to excel. So in this room and for this conference, we have nearly 1,000 of you, 1,000 individual members that create our collective maternal and child health strength. So I'd like to have you take a moment and turn to a neighbor or two and thank them for everything that they've done day in and day out for the women, children, and families of our population. Mm-hmm. Yay. Awesome. Oh my gosh, this could go on forever. I feel like we said not only 1,000 thank yous, but 2,000, maybe 3,000 thank yous. That's great. Okay, so for the next few minutes, we'll be turning to recognize a couple of our distinguished colleagues. And the first one, I'm pleased to present the Excellence in State Maternal and Child Health Leadership Award. In 2012, this award was created to recognize an outstanding state maternal and child health professional whose career in MCH has made significant contributions to their state's MCH program, state maternal and child health outcomes, and otherwise promoting and protecting the health of women, children, and families in their state. The winner of this year's Excellence in State Maternal and Child Health Leadership is Dr. Alish Klein of Rhode Island. While she's making her way to the stage, I want to share a little bit about her with you. Dr. Klein is the Rhode Island Department of Health Medical Director for the Division of Community, Health and Equity, and the Maternal and Child Health Title V program, and the Division of Environmental Health. That is quite a portfolio. Dr. Klein has worked at the Rhode Island Department of Health since 2014 and has practiced pediatrics for 20 years in Rhode Island. She's a board member and past president of the Rhode Island chapter of the American Academy of Pediatrics and co-chair of the Rhode Island Task Force on Premature Births. Since joining the Rhode Island Department of Health, Dr. Klein has been an inspirational maternal and child health public health leader and a leadership style based on collaboration, trust, science, and the all-important humor. Dr. Klein supports the mission of the Rhode Island Department of Health to prevent disease and protect and promote health and safety of the people of Rhode Island. It has been her life's work to improve the health of Rhode Island's mothers, children, and families. Okay, thank you, Dr. Klein, for your contributions. I am now so pleased to present the Merle McPherson Leadership Award. This award is named for Dr. Merle McPherson, who served as the director of the Maternal and Child Health Bureau's Division of Services for Children with Special Health Needs from 1987 to 2006. Dr. McPherson left a legacy of leadership and vision for how to create a new model of family-centered healthcare delivery for children and youth with special healthcare needs. The award is given to a family representative or family professionals who have made exemplary contributions to further family and professional collaboration. This year's award goes to Donna Yarbrough of the Virginia Commonwealth University Partnership for People with Disabilities. While she's coming to the stage with her daughter, Brooke, let me share a little bit about her with you. Dana is a community sports specialist, supports specialist, and assistant director, strategic initiatives at the Partnership for People with Disabilities, Virginia's University Center for Excellence in Developmental Disabilities, located at Virginia Commonwealth University. Among her many roles at UCV, or VCU, I'm a little dyslexic this morning, Dana directs and supports diverse families and of children and adults with developmental disabilities to become effective advocates for their children and leaders for systems change. Dana has worked tirelessly to expand education and training of health professionals from all disciplines, as well as professionals in other sectors, community partners, and payers about what their role is in linking to and working with families to improve the health care experience and improve health outcomes. Dana is also the AMCHP Family Delegate for Virginia and the chair of AMCHP's Family and Youth Leadership Committee. So Dana has brought on stage with her her daughter, Brooke, and thank you for accepting this award for the Merle McPherson Leadership. Take her out of the way.
Okay. I was told this was like the Grammys. I have about 90 seconds before the microphone goes down and the orchestra plays me off. So So if you'll indulge just a moment. Got a little bit of a workout coming up here with her. Phew. Brooke has something she wants to say, so I have to get it ready. So I'm extremely honored, thrilled, and humbled to receive such an important award named after a woman who transformed the lives of women, children, and youth with special health care needs. How fitting as we just celebrated International Women's Day last Friday. When I told Brooke I was receiving the Merle McPherson Award, she said, are you ready for this?
Of course you did. You rock, Mama. Does this mean you are now the boss of all moms?
So Brooke thinks I'm the boss of all moms now. So, I'll take. I'm not sure what I'm going to do with all that power, but we'll see. So I'm standing here today because of Brooke, and she helped me move from working just a variety of jobs into a career that I love, and because of the parents who shone a light on the path in front of me. I want to thank AMCHP for their commitment to authentically engaging with families and carrying on Merle's legacy through family leadership activities. I must thank the Virginia Department of Health's Title V team. They're out here, somewhere here. Cornelia, Marcus, Daphne, Shamari, Carla, to name just a few. Your unwavering trust in me and all of the wild ideas that I bring often to the table. And thank you especially to Cornelia for nominating me for this award. I'm very humbled. I also am glad that Jen Reese and Dina Buck are here from Virginia Commonwealth University, where we work tirelessly with our teams to ensure that children and adults with disabilities can live, learn, work, and play in communities. We believe that inclusion means all, not some. Awards like this tend to make you look back over your life. There were some cringeworthy moments, like when they moved a girl out of Boston area into the foothills of the Blue Ridge Mountains in Virginia, the moonshine capital. And I don't know what they expected because we party wicked hard. There were the, oh shit, I just had a baby 12 weeks early, what am I going to do moments. There were the, I have 99 problems and a wall ain't one moments. There were the moments working alongside Laura Warren, Joni Bruce, Mo Schroeder, and others in the room and that aren't here today to help sustain and form Parent to Parent USA as a cradle of support for families just learning of their child's diagnosis. There were moments moving from the token parent at the table in the late 1990s to managing a center with over $1.3 million in funding and 24 parents and people with disabilities on staff. And the moment when Brooke left, she's bored already, the moment when Brooke left 20 years of preschool and K-12 education with just an IEP certificate, and she started a dog boarding business in spite of what the professionals around her said about her never working. And finally, yeah, there you go, girl. She has 32 clients with 4 legs. I'm looking for one with a 3-legged client. I've always said it's not my job to change Brooke, but to change the world around her. So I'll continue to do that with my new powers, especially as the boss of all moms. Thank you.
Ladies and gentlemen, please welcome to the stage our moderator for today's session, AMCHP Associate Director of Health Systems Transformation, Stacy Collins.
Good morning, everyone. I just want to say that Jonathan is an incredible CEO in his short time with AMCHP. He had a tough act to follow with our former CEO, Lori Freeman, but so far he's doing an incredible job. And right now I can't see him, but he's somewhere out there. So thank you, Jonathan. Okay, so as the Associate Director of Health Systems Transformation, I lead a team that's increasingly focused on state and federal policy related to mental health and substance use disorders. We're here this morning to discuss how these issues affect MCH populations, how mental health and substance use disorders intersect, how states and communities can respond, and perhaps most importantly, we'll have a discussion of the underlying issues we need to address in order to be effective. We'll do this with a keynote presentation and a panel discussion. Leading us off will be Nzinga Harrison, who will address some of the clinical issues in mental health and substance use disorders. Then Nzinga and I will be joined by 3 guests who will address these issues from 3 different perspectives. We'll talk about various approaches and challenges to engaging marginalized communities to address mental health and substance abuse. So now it's my pleasure to introduce Dr. Nzinga Harrison. Hi, Nzinga.
Hi. I didn't know I'd get to stand next to you while you do that.
Nzinga Harrison is a very well-respected physician and educator, and she's the Chief Medical Officer for Behavioral Health, and a member of the clinical adjunct faculty in the nursing school at Emory University and Morehouse School of Medicine. Nzinga has written and presented several articles and workshops on the medical aspects of addiction and other psychiatric disorders. Welcome, Nzinga.
Thank you.
Happy to have you here.
Thank you. Good morning, everybody. Okay, so this is my first time on this clicker, so I think the big green button should do yep. All right, good morning. So like she said, I'm a physician. My specialties are psychiatry and addiction medicine. And I have been tasked with trying to lay the foundation for what will be an amazing panel about the biology, psychology, cultural, spiritual, social aspects, and how those can inform policy for substance use disorders and other mental health disorders and maternal child health. And so you can see the title that I gave this talk is Generational Effects of Substance Use and Other Mental Health Disorders on Maternal Child Health, a Framework for Prevention and Early Intervention. I task you to say that 10 times in a row without errors. I'm the Chief Medical Officer for AMCHP Behavioral Health, and also just want to mention co-founder of an organization, Physicians for Criminal Justice Reform. I encourage all of you guys to Google it and look it up. Okay, friendly crowd, friendly crowd. So they put the clock on me for 25 minutes, at which time the music will play and the Sandman will come usher me off. So I've packed this 25 minutes like so full. I always start any talk about substance use disorders or other mental health disorders, 1 with biology and 2 with a soapbox. I think in the last 13 years that I've been giving talks to crowds, I say like, this time I'm not gonna get on a soapbox, and it has never happened. So I'm just gonna start today out with my soapbox, which is that substance use disorders are mental health disorders, okay? So this, thank you, oh my goodness. Usually I'll start with a soapbox like that, and then I'm like, and I'll fight anybody who challenges me, but I didn't have to fight, you guys clapped. So these disorders start in the brain, and what I really want to talk about is using the biology of the disorder and the natural history of the disorder to think about when we form policy, and also to undermine the stigma and discrimination that can happen against individuals or family members or support systems, communities that experience these disorders. So even though I'll say I intended to get a master's of public health, but then I had 2 kids, and I was like, oh, master's in mothering. I was like 8 months pregnant when I took my first MPH class. So I feel like I'm among friends here and hope that I'm public health minded, but if I make any mistakes, just give it to me, okay? So we're gonna talk to the neurobiology and physiology of substance use and mental health disorders, which I say are the same thing, generational effects of maternal substance use and other mental health disorders, the impact that that can have on maternal child health, and then a framework for considering prevention and early intervention. So I want to introduce the framework early before we jump into neurobiology. It's a framework you've all heard of course. It's biopsychosocial, okay? I'm going to add on to biopsychosocial, spiritual, cultural, political, okay? So it's like biopsychosocial, spiritual, cultural, political, like supercalifragilisticexpialidocious. So looking at neurobiology of substance use disorders and other mental health disorders, we're really looking at two systems in the brain. And so we're going to start, I'm going to put a picture of the brain up here for you, but if you will just go on this journey with me. I'm drilling this down to very simple. We're going to take the brain in two parts. The deep brain, which we're all born with, that's where our automatic functions are, that's where our reflexes are, that's where our emotions are. Okay, so if we look in the deep brain, if you connect this line and this line, where those two lines connect in the middle of my head is where I'm talking about, deep in the center of the brain. That is the part of the brain that all animals share, okay? And then the other part of the brain I want to talk about is the cortex. So that's the overlying, when you look at a picture of the brain and you see those folds and it's shaped like a boxing glove, you're looking at the cortex. That's what we think of when we think of the brain. That's where our voluntary functions are, decision-making, executive skill set, impulse control, okay? That's going to be the prefrontal cortex. So I meant to start out with the rules of my talk, which is like if I ask a question, you have to answer it, okay? You guys are kind of getting off a little bit because these lights are bright, so I can't necessarily like pick people out because I can't see you. But anyway, I know you're there, even with the bright lights. So if I say prefrontal cortex, then I want you to automatically associate that with two words. One, voluntary, two, thinking, okay? So I say prefrontal cortex, you say voluntary thinking. You know what? You guys are winning this morning. Okay, so the other part of the brain is the deep brain. That's where our emotions are, and that's automatic, okay? This is what you see up here on the board, which is limbic system and dopamine. So if I say deep brain, I want you to say feelings automatic. Deep brain? Feelings automatic. Prefrontal cortex? Deep brain? Prefrontal cortex? Okay, you'll see why I spend so much time on this. When we look in the deep brain, we're talking about two systems as it relates to substance use and other mental health disorders, the limbic system and the dopamine pathway, okay? The limbic system really has so much to do with serotonin, dopamine also, but serotonin, norepinephrine, depression, anxiety, feeling fulfilled, ability to focus, psychotic disorders. This is all coming from the limbic system. It has a lot of structures that we'll get into on the next slide. The dopamine system, also known as the reward system, okay? But I like to not call it the reward system. I like to call it the motivation pathway because reward seems like, we know this is intimately involved in addiction, psychotic disorders, and actually Parkinson's, but that's a non sequitur. When you call it the reward pathway, then it reinforces that idea of voluntariness and enjoyment that is inappropriately attached to substance use disorders, okay? So I want to call out reward pathway and just call it the motivation pathway because if you look at it phylogenetically, evolutionarily, the purpose of the dopamine pathway is to keep us alive. It's motivation for the individual organism and for the species to propagate and survive into the future, okay? So motivation pathway, limbic system. The limbic system is responsible for fight or flight, anxiety, depression, also keeping you alive. So here's the limbic system. Let's see, does this have a little pointer? Ha! Okay, so if we look at the systems, and we're going to start from the bottom. So olfactory bulb is smell. Smell is your most powerful evocateur of memory, okay? This is in the deep brain, so is this automatic or voluntary? Okay, limbic system automatic. So what's happening is that your nose is constantly, and all of your senses, constantly collecting information from the external environment and the internal environment, feeding that information through the hypothalamus, the amygdala, the hippocampus, the thalamus, to the frontal lobe. Okay? Your frontal lobe, also prefrontal cortex, those are synonyms. That decides what does that information mean and what should I do about that information. This is the CEO, okay? Frontal lobe, prefrontal cortex. So you're walking down the street, minding your own business, and you're like, Why am I thinking about grandma? Well, it's because you happened to walk by a bakery that was cooking apple pie and you smelled it, and that triggered your hippocampus to remember grandpa, and then your grandma, and then your prefrontal cortex gave you a thought that said, I should call grandma and see how she's doing. All of that happened outside of your consciousness, okay? Lands on the prefrontal cortex as the final step. The thalamus and the hypothalamus translate information from your brain into your body. So it's the same neural network that goes from the top to the bottom. But I say it's kind of like, even though they're using all the same chemicals and all the same nerves, it's like your brain speaks Spanish and your body speaks Portuguese. Similar, but not the same, right? So thalamus and hypothalamus are your translators. So the information goes both ways, okay? If I see something, before it takes 1,500 milliseconds to get to my prefrontal cortex. It only takes 500 milliseconds for my amygdala, whoops, wrong button, my amygdala to give me a fear signal. So I see something, my amygdala says that's a threat. Hypothalamus sends that information down to my cardiovascular system. My heart beats faster, my GI system. My stomach churns, my mouth. It gets dry, my eyes. My pupils dilate. Thalamus takes all of that internal information, sends it up to prefrontal cortex and says, there is danger, because amygdala told me so and all of my internal organs confirmed it. And then prefrontal cortex says, well, what is the source of this danger and what should I do about it? Okay? Hold on to that. We get to, I looked at this and I was like, I have no idea what button to push. All of a sudden, I was lost. We looked at the motivation pathway. I got so into the prefrontal cortex. We look at the motivation pathway, okay? Also in the deep brain, so is this automatic or voluntary? This is automatic, thank you. The motivation pathway, remember I told you, evolutionary, its entire purpose is to keep you alive as an individual organism, but also to propagate the existence of the species. And so if we look at the natural determinants for a dopamine signal, food, needed to live, water, needed to live, sex, needed to live, okay? Needed for the species to live, for sure. Nurturing. You know how you know what Jonathan did for us at the beginning of this when he said, everybody give a high five? He gave us all dopamine signals, okay? And that dopamine signal triggered, hold on now, don't let me get too fancy. Dopamine signal was like, oh, serotonin. And then you had all of these changes in your internal organs, and they came up to the prefrontal cortex, and prefrontal cortex said, I like that. So food, water, sex, nurturing. Now, this is what's important. Those are the natural determinants of a dopamine signal. What we know is every single drug or behavior of abuse generates a dopamine signal way bigger than any of these natural determinants ever could. And so if you think of it metaphorically, and this is not like scientifically 10 to the third, 10 to the ninth, but if you look at the size of the dopamine signal that food, water, sex, nurturing generates, like a light bulb, right? Ping, that high five was wonderful. But then you do a line of cocaine, and it's like the brightness of the sun. It's like these lights shining in my eyeballs, like cocaine level dopamine right now. Okay? And so if the size of the dopamine signal gives your prefrontal cortex the information about how important that is, what's more important, cocaine or food? Ever known somebody who chose cocaine over food? So what I'm using is biology to undermine the language and the perception and the thoughts, the way we talk about substance use disorder. Ever knew somebody who chose methamphetamine over their family, over nurturing? Okay? And so this sounds like I'm telling a grim story, like, oh, we have no choice. The beautiful thing about it is as much as the deep brain, and look where this ends. This dopamine pathway is a 3-neuron system. Starts in the deep brain at the nucleus accumbens, feeds forward to the, starts in the deep brain at the VTA, ventral tegmental area, whatever, y'all don't care about that. Feeds forward to the nucleus accumbens, and then look where it ends. Prefrontal cortex. Okay, so when you do a line of cocaine and that dopamine signal comes and says, oh, This is more important than food. That information gets fed forward, lands on the prefrontal cortex, and says, we need this to survive, make sure we never go without it. This is more important than anything else that has ever generated a dopamine signal for us. Make sure we never go without it, okay? Once this pathway is burned, it's there, period. So when we talk about the natural history of substance use disorder, the reason recovery is a lifetime effort is because the brain does not forget. Just like I'm walking down the street minding my own business and I smell apple pie and then I don't even know why I think to myself I need to call grandma, okay? I'm walking down the street and I smell something. I've been in recovery 20 years. I smell something that smells like crack burning. That pathway is burned. And the prefrontal cortex is going to make a plan, okay? So when we talk about policy, this is the last thing I want to make an emphasis on nurturing here. Humans are pack animals. We need a pack. So when we think about the biology of nurturing and being pack animals, when an animal gets kicked out of the pack, what does it do? Anyone? You sleep? It dies. It slinks away and it dies, right? What do we do to people who develop substance use disorders? We kick them out of the pack. So when you're thinking about the importance of culture, because culture is a pack. The importance of spirituality, spirituality is about connectingness. That's a pack. When you think about policy and we, separate our funding streams for mental health disorders and substance use disorders, like shooting ourselves in the feet, both of them. You usually just say foot, but I said feet, so I acted like it's on purpose. When we separate substance use, mental health disorders, and physical health disorders, shooting ourselves in the whatever, our heart, organs, whatever, right? We are not doing ourselves a service because our biology floats all the way through. And if we're thinking about policy that really creates a pack and takes care of the whole person, the whole community, then we have to be thinking out trying to braid those funding streams so that we can just reach in a pot and provide a person with whatever it is that they need. So now that I laid that foundation with biology, then I want to talk about the biopsychosocial, spiritual, cultural, political. I think I'm going to what do you say, trademark that or something. I'm trying to make it my own. Structure, okay? We know that every illness, no matter what it is biopsychosocial, cultural, spiritual, and political, because politics come out of our biology, our psychology, and our social networks, right? So substance use disorder is no different. If we look at the genetic heritability of substance use disorders, it's 50 to 60%. That's higher than high blood pressure, has a higher genetic component than high blood pressure, has a higher genetic component than asthma, has a higher genetic component than type 1 diabetes, okay? But because the symptoms are behavioral and emotional, we get deluded into the idea that there's more choice than there is. And so especially if we think about it over the spectrum, over the lifetime of brain development, so I'll tell you, you're born with your deep brain. Your prefrontal cortex is pretty much useless to you when you first come out of the womb, right? That's why as soon as you wet your diaper, you cry. Now, we are all adults, right? If you accidentally wet your diaper, maybe you're not wearing a diaper. If you accidentally wet yourself right now, you would want to cry. But your prefrontal cortex would enact some impulse control and you would make a plan to get out of here without any of us knowing you had wet your pants, right? So you're born with your deep brain, and over time your prefrontal cortex develops. So I say you don't even know that you need a CEO. Remember your prefrontal, you're a new company, you're born, and you're like, whatever, making your product, you're like, life is good, I cry and people come take care of me. And then you get into adolescence and you think you know what you're doing running that company, but you don't even realize you need a CEO. And then you get somewhere into your late teens and you're like, maybe I need a leader, right? And you create a CEO position and you go out recruiting. And then you get into your mid-20s and you hire a CEO that's never been a CEO before. This is brain development. And what's actually happened is that the neural pathways from the prefrontal cortex are myelinating, getting myelin on all of those nerves, pruning off all the nerves we don't need, so that prefrontal cortex can exert top-level control on the deep brain. So we grow from being completely at the mercy of our natural impulses to developing impulse control and the ability to make decisions despite impulses. So I'm in recovery and I see somebody smoking marijuana, and rehab has taught my CEO how to respond in that situation without using. The issue is when we look at substance use disorders over the lifespan, biologically, psychologically, socially, then we know there are genetic vulnerabilities. I told you 50 to 60%. Okay? We know that psychosocial, cultural, spiritual, political factors can magnify that biological risk. So like I have tons of substance use disorders and schizophrenia throughout my family. I tell my kids, listen, my sons are 12 and 13, they're amazing. Listen, your friends might be able to smoke some weed and have a good time. You smoke some weed, you're gonna get schizophrenia. They already know. Okay? Listen, your friends in college might be able to do a line of cocaine and get away with it. You do a line of cocaine, things are gonna change in a big way for you. Okay? You are genetically loaded, right? Now, we've tried to undermine that genetic risk, and this gets to the social, cultural policy, all of that. What is our culture around substance abuse? Don't talk about it. Everybody knows Uncle Johnny has alcoholism. We're just gonna pretend like nobody knows, right? In my family, my favorite uncle has severe cocaine use disorder. And everybody knew on Thanksgiving, make sure you hide your purse, because he was gonna steal everybody's wallet and eat dinner and then be like, goodbye, and we all love you. Like, we all knew that's how it was. But nobody said, because he has a substance use disorder, can we get him some help? So the first thing is like, talk about it. When we're thinking about these policies, early intervention, this is school. This is young. I went and did career day, and I was talking about substance use disorders to the second graders, and the teachers were mortified. But I was like, this is your brain and drugs. And the teacher was like, what? I didn't know that's what we're doing. I was like, ha, gotcha. Anyway, so the second graders were like, oh, you mean like when my daddy goes outside to smoke because he doesn't want mommy to know? And I was like, yes. And the other was like, or when mommy hides her beer cans and she doesn't think we can find them? And I was like, so the second graders, they know, okay? So when we thinking about the biology and the natural history of the disease, okay, just like high blood pressure, if you don't take your medicine, if you don't keep your stress low, if you get sick otherwise, your blood pressure is going to go up. Substance use disorders and mental health disorders, depression, anxiety, schizophrenia, ADHD, whatever, they are all the same. So when we're thinking about a framework, and I just want to touch on this, when we're thinking about a framework for prevention and early intervention, I'm going to leave you with a few things. I got 3 minutes and 26, 25, 24 seconds to go, okay? Biologically, you are born with your genetic risk, 50 to 60%. We can magnify that risk by the psychosocial conditions we create, or we can mitigate that risk by the psychosocial situations that we create, cultural, spiritual, political, okay? So the way we magnify that risk is by criminalizing substance use so that people won't get help for it, stigmatizing it so that people can't speak up, not having adequate access to treatment services, not having treatment services that support the entire person, family, community, not having services that support the workers that are in those services, right? When you see these beautiful stories and it's like, my caseworker helped me, and without her, I wouldn't be sober for 20 years and I wouldn't have my kids with me. It's because that caseworker had a system that supported her in supporting bringing that person into a pack. Compassion and stability. That caseworker worked in a system where they could be there for 20 years so that that woman didn't have a different caseworker every 3 months. Right? Stability. Hey, come on now. Stability, 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 stability. I cannot emphasize this enough. As the brain is developing in the womb, remember I said that pathway is burned. So most moms don't start using when they get pregnant. They're already using, right? That fetus gets a pathway burned. That dopamine pathway gets burned. And then the younger you get kicked out of the pack, the less likely you are to thrive. So we need to be thinking, and then generationally, so I said we can mitigate or we can magnify that risk. Epigenetics, we literally change the DNA and magnify the genetic risk for substance use and other mental health disorders generation to generation to generation. And so what I'm gonna say to end is that psychosocial, culturally, spiritually, politically, we have to be thinking about how do our policies create a pack? How do our policies bring pride to being able to stand up to say, I had alcohol use disorder. I drank when I was pregnant. Because mothers get an even higher level of stigma for using than other groups do, right? And then kids actually get that stigma act also once they get labeled a bad kid, which can happen very early. And so how do we create policies and systems, one, that undermine the traumas and adverse early life experiences that are, so what those do in the brain neurobiologically is that they actually shore up the deep brain and reduce the connections of the prefrontal cortex, reduce the development of the prefrontal cortex. So we're expecting these folks to be able to make decisions, and we've created conditions that didn't support their brain development to be in a position to be able to make those decisions. And so I'm gonna close it out. This is my last slide. This is classic Dr. Harrison right here, okay? So this is my last slide. At least I didn't fall, because that would have been like viral. They would have been like, did you see what happened in AMCHP? And my husband would have been like, oh my God, that is so you. To close it out, I'm hoping that I'm putting a little bit of a fine point and maybe just a little tweak when you're thinking about your programs that you're running, your policies that you're advocating for, your systems that you're creating, to remember the brain, remember the biology, remember the natural history, remember that we have the responsibility to mitigate the biological risk that these kids are born with rather than to maximize it. And that's it. Thank you. Thank you. I'll stop it.
Sharice, that was amazing. Thank you so much.
Thank you.
I'm going to try to read some of this without my glasses so I don't knock off all this robotic equipment they got me hooked up to. Okay, our next panelist, or I should say our first panelist, is Sharice Scott. Sharice is the founder and CEO of Sister Reach. Sharice has been working in the reproductive justice movement for more than 10 years. As a Black woman, Sharice knows exactly what it means to not have the necessary social supports in order to make informed decisions about her reproductive health. In that same spirit, Sharice also knows how life changes positively when a woman is empowered with access and information about her reproductive and sexual health. In 2011, Sharice founded Sister Reach, the only reproductive justice organization in the state of Tennessee. With the visionary support of her mother and grandmother, I love that makes me tear up, I love that. Sister Reach focuses on empowering women and girls of color, poor women, rural women, and their families. Some of Sister Reach's accomplishments under Sharice's leadership include releasing a 2015 report on the need for comprehensive sexuality education for Southern youth of color, and the rollout of a state and nationally based clergy cohort partnering with and training faith leaders on social justice issues. Can we welcome Sharice?
Good morning. I decided to bring my laptop up here with me, so hope that works okay for everyone. Well, I appreciate the opportunity to share the work of our team at Sister Reach with all of you. Sister Reach is an advocate for the reproductive autonomy of women and teens of color, poor and rural women, queer folks, gender nonconforming people, and their families through the framework of reproductive justice. Our mission is to empower people to lead healthy lives, raise healthy families, and live in sustainable and healthy communities. We work from a three-pronged strategy of education, policy and advocacy, and culture change work. We apply the reproductive justice framework as the bedrock of our organization as it centers the human rights of those most vulnerable, those ignored, and who are the last to be heard and are often rendered silent because of their race, class, socioeconomic status, sexual orientation, religious affiliation, immigration status, age, and in this case, sexual behavior practice. The reproductive justice framework rests on 6 core principles that have been developed over the last 25 years. They state that every woman and individual has the human right to decide if and when they will have a baby and the conditions under which they will give birth, adopt, or parent. Decide if they will not have a baby and their options for preventing or ending a pregnancy. The ability to parent the children they already have with the necessary social supports and safe environments and healthy communities, and without fear of violence from individuals or the government. The right to express sexuality and spirituality without violence or shame. A quality of life and sustainability before and beyond the ability to give birth or parent. Bodily autonomy free from all forms of reproductive oppression, which is the control and exploitation of women, girls, and individuals through our bodies, sexuality, labor, fertility, and reproduction in violation of our human rights. For almost 8 years, we have been leveraging this important framework to shift the political, social, and public health culture around marginalized women, youth, and individuals in Tennessee and across the country. We've also committed to educating the people we serve so that they might have practical tools to thrive and be healthy while navigating their reproductive lives. This work includes our LARC advocacy work across the state, educating women about the benefits of long-acting reversible contraception, while lifting up the coercive nature in which LARC is offered to low-income women, teens, undocumented, incarcerated, and drug-using women in Tennessee. During these discussions, we've taken the time to ask participants if they felt empowered and heard by their providers. So far, the majority report that they have not felt empowered or supported by their providers and have experienced great difficulty communicating their needs or pushback during visits. Their feedback, mixed with bipartisan and anti-choice legislation and policies preferencing LARC as a magic bullet to unplanned pregnancy, and the verified sterilization and coercive practices of drug courts across the state of Tennessee, targeting drug-dependent women, forced us to expand our scope of advocacy work. We now hold reproductive justice trainings with providers and public health officials in Tennessee and across the Deep South, emphasizing the danger of complicit bias and inviting practitioners to expand their services to include comprehensive birth control options counseling, comprehensive sexuality education, cultural humility as an evolving and consistent practice, and to shift their model of care to a patient-led model. I realize that a patient-centered model is a model that the public health community has committed to use, and if applied properly, as crafted and understood, it should be effective. But women remain unheard, they remain coerced, they remain disempowered in the medical setting, and their sexual behavior practices have not changed. At Sister Reach, we have shifted our ask of providers to consider a patient-led model, as it ensures, as reproductive justice does, that those most marginalized should be regarded as an expert of their lives, bodies, and decisions. Patient-led care is not driven by funding, coding for billing, or payment reimbursement. It is not informed by provider bias or their personal or institutional piety. Patient-led care is not limited by race, class, gender, socioeconomic status, age, or immigration status. Patient-led care that provides the provider's behavior shift to support the patient's learning capacity, buy-in, and ultimately their behavior change. Patient-led care is not an instant fix, but requires that providers take the necessary time to cultivate a relationship with their patients, establish trust with the patient, and leave knowing that your patient will make the best decisions for their health because you trust the knowledge, information, and time you have invested in that patient. It is not the responsibility of your patients to be their own doctor. However, with the shift in provider behavior, you can walk away from that patient knowing you have done everything within your scope of expertise to ensure they have all the tools they need to be self-determining and responsible with their health and wellness. Many of you may say you don't have the time or capacity to offer this type of care. I say that thinking along those lines is why we are here, fighting a multitude of crises within the public, behavioral, and mental health communities. For example, the uptick of LARC usage is not a marker of behavior change, nor should any method of birth control ever inform that marker, as it only reduces unplanned pregnancies. But it is currently revered, much like Seasonal, the patch, and NuvaRing once were, as the answer to abortion, unplanned pregnancy, and even poverty. Yet LARC does not and will not curb STI transmission. It does not serve high reproductive and sexual risk populations to demonize barrier methods, but places them in even more danger. LARC are just as effective as woman-controlled methods, granted the same time and investment to education, buy-in, and access are afforded to the people who will use them. And for many women, in particularly women and teens of color, undocumented and incarcerated women, they remain disproportionately underserved while their reproductive and bodily autonomy remains in the hands of their provider's bias, their provider's personal or institutional piety, their provider's lack of capacity, and their provider's lack of trust in their ability to control their own fertility and govern their own sexual behaviors. I came to this work as a woman who did not understand my fertility. I was not educated about my body. I did not have information on very basic reproductive health topics like ovulation, STI transmission, or even proper condom usage. I have 3 abortions under my belt to demonstrate my lack of ignorance around these basic topics that are forbidden to teach in the state of Tennessee without a $500 penalty per child if you teach anything other than the abstinence-mandated programs. Life-saving topics. It was not until a reproductive justice advocate asked me about my sexual behavior, my comforts, fears, and uncertainty about my body and sexual experiences, then showed me how to chart my menstrual cycle and understand my fertility, that I was able to change the trajectory of my life and reproductive health experiences. I have not needed another abortion because I now understand my fertility, how to properly use barrier methods, and am empowered and equipped enough to teach others about their bodies. I am now better educated about barrier methods, emergency contraception, and more confident around condom negotiation. Education still works if we work it. As we learned in Dr. Harrison's keynote earlier, cultural, social, spiritual, and political support matters. I am a living witness to the positive outcomes of patient-led care and investment. These positive outcomes will and do translate across your patient base. On Thursday, Sister Reach will share our research on the impact of the fetal assault law of 2014 through 2016 and how the response of lawmakers, medical providers, and I just lost my place, I'm so sorry. Okay, let me start over here. Okay, so on Thursday, Sister Reach will share our research on the impact of the fetal assault law of 2014 through 16 and how the response of lawmakers, medical providers, the drug court, and anti-choice community combined to curb drug usage among women placed them in harm. The summaries of our LARC advocacy work and research study have been uploaded by the conference for you to review at your leisure. The law allowed the state of Tennessee to arrest pregnant women for the use of opioids and other drugs during pregnancy if the child was exposed to the drug. Those arrested and charged under the fetal assault law faced a penalty of up to 15 years in prison and loss of child custody. Prior to this legislation, and with the exception of a law penalizing inhalation of chemical fumes, no one in Tennessee, pregnant or not, could be arrested or punished for using or being dependent on drugs. Therefore, this legislation made drug use, as opposed to possession, a special crime only for pregnant women. During the years the law was in effect, a reported 124 women were arrested statewide. More importantly, early assessments of the impact of the law showed that pregnant women were avoiding prenatal care, having abortions to avoid arrest after labor and delivery, fleeing Tennessee to give birth in neighboring states, and giving birth at home rather than in hospitals. Additionally, the law seemed to disadvantage women who traditionally have poor access to health care services. Our qualitative study documents the experiences of marginalized women, defined as women with limited financial assets or living in rural areas of the state, directly and indirectly impacted by the fetal assault law. 80% of the women in our listening sessions were raised in households where substance abuse was common. More than 2/3 of the women were unemployed at the time of the discussion and reporting having sex in exchange for money, drugs, or other basic needs over the course of their life. The stress of limited finances was compounded by a history of domestic and sexual abuse for almost all participants, highlighting the extreme life experience and vulnerability of substance-using women. We add to the knowledge base by showing the indelible impact of custody loss on women's well-being and the insufficiency of a 28-day detox program as a treatment option. The loss of a child was upsetting and resulted in some women resuming drug activity to cope with the stress of loss. Challenges with child protective services, lack of structural supports, and personal challenges made it impossible for many women in the study to regain custody of their children. The women who participated in this study are the same as many of your patients. They have real lives, real disparities and conditions which inform their efficacy. However, without a paradigm shift in care models, we cannot expect their lives or behaviors to change. To honor their lives and humanize their experiences, we have modeled what I am asking you to do. We asked the participants to offer their recommendations to lawmakers and the public health community on what they believed they needed to thrive and survive. We listened to them as the experts of their experiences. We centered their requests as wisdom-informed beyond theory and rhetoric from people and institutions that do not walk in their shoes or live their lives. A person's ability to control their body is directly related to what is happening in their life and community. Controlling people's bodies is a direct pathway to controlling entire communities. Human rights protections and violations determine a person's ability to be self-determining about their body and to live free from violence and coercion. Therefore, I will leave you with these last thoughts as crafted by women of color with our vision for reproductive justice. Reproductive justice will be achieved when Indigenous individuals and individuals of color, marginalized people, and drug-using women have the power to protect and advance our human rights, determine the number and spacing of our children, protect our bodily integrity, protect our right to parent our children, improve the quality of the environment in which we live, obtain the necessary social supports to live healthy lives in healthy families and in safe and sustainable communities. Thank you.
Thank you, Sharice. Thank you, Sharice. Okay, our next speaker is Jenny Baker. Jenny is a public health specialist in the Adolescent Health Program Jenny Baker is with the Alaska Public Health Department. She is with the Adolescent Health Program within the Women's, Children's, and Family Health section of the Alaska Department of Health and Social Services. Currently, she facilitates the advisory and community intervention efforts of the Youth Alliance for a Healthier Alaska. And she has a few colleagues out here. And coordinates the programmatic and evaluation efforts of the Teen and Unintended Pregnancy Prevention Program. Jenny works closely with community health clinics in the piloting of an adolescent-friendly clinic assessment, checklist, and improvement tool. Welcome, Jenny.
Thank you, Stacy. Where'd that clicker go? Oh, it's all right. I definitely feel like I belong on Star Trek right now. Oh, this isn't that bad. No? I can see you. Can you see me? Thank you very much for the invitation, AMCHP, and to bring youth voice to the center today, as well as with all of these amazingly powerful women. I feel very honored to be up here, and my hope is that I honor also the Alaska Native people and youth that I plan on talking a bit about today, especially in their centuries of pain and process of reintegrating their cultural processes for healing and hope. Many Alaska Native peoples sometimes stuff the fact of what they've experienced from that they pretend it didn't happen because of so much intergenerational trauma that has happened. Hawk is The Way of a Human Being by Harold Napoleon, and he says that substance abuse and mental health exist within the spirit as well. So knowing that we need to start healing a lot of our populations starting at the spirit and addressing those pieces is essential. Button, okay. So we did already talk about the social determinants of health and the socio-ecological framework, but I just wanted to share with you some of the impacts that what the Alaska Native peoples call the Great Death. Anywhere from many influenza and infections over the course of hundreds of years, and the culture of silence associated with boarding schools has been integrated into their genetic pathways as well, and influences how they experience life and how their families experience life and how their families to come will experience life. This is an idea of internalized oppression. The challenges to this work and addressing this through a really important determinants of health framework, especially if we look at adverse childhood experiences and even addressing, as Dr. Harrison said, epigenetics. We have to stop just focusing on problem behaviors like, oh, that youth is cutting, or oh, they're binge drinking, instead of it really looking at what they've experienced and how we can help them heal. And there's a lot of really great work that has been done in the state of Alaska. My mentor and adolescent health rock star, Becky Judd, has updated most recently this month the shared risk and protective factors impacting adolescent behaviors, including positive youth development. Extensive research has demonstrated the association between community conditions, relationships, personal characteristics, and the experience of harmful behaviors in adolescents ages 10 to 19. This approach prioritizes factors linked to healthy youth behaviors, not just behaviors themselves, or unhealthy behaviors, not just the behaviors themselves. So those factors that are associated are really important. So if you see here, we're looking at the negative and positive shared risk and protective factors for mental health, substance abuse, and violence. And you'll see that the negative side, but I really want to focus on the positive side today, and talk about the connection to school and family, and also especially the connection to supportive adults, so supportive others. How many of you can remember one person in your youth that impacted your life today? And if you don't have a person that was in your youth that positively impacted you into your adulthood, then think about a youth in your life and how you are responsible for that, also supporting them, and how you may also be the supportive adult in their life. Adolescent health coordinators focus on the strength of youth through positive youth development framework to assist in promoting protective factors. This is very important when we think about social emotional competence and self-regulation, cultural identity and connection, and also that connection to family. So within supportive adult relationships, there's some great work being done in Alaska related to youth-adult partnerships, like the Youth Alliance for Healthier Alaska and many other work. And I just wanted to give a shout out to the youth from Puerto Rico, and also the Texas Youth Action Network. If you weren't able to see some of their amazing work this weekend and into this week, youth will be more on this stage, my hopes, in the future. That youth will be integrated and part of the conversation, and even children with special health care needs, in addition to incorporating them into our research assessments and frameworks. Other pieces are youth mattering grants, so really trying to emphasize that fact that youth matter in the community, helping them feel comfortable, confident in their community, and talking about Lead On for Peace and Equality, where youth are given a safe structure within to express strong emotions, but also encouraged to boost their involvement in the community, which is also a protective factor, and to do community action projects that impact their community as well. We want to empower youth to be involved in authentic community engagement, and also to really work with providers, supportive adults, with motivational interviewing strategies, and youth-friendly clinics in addition, where clinicians are able to ask youth what they need. So you'll see here in this slide, one of our peer educators in Homer, Alaska, from the rec room, is doing the pretzel activity. And I'm just going to ask you to do that with me really quick. So this is about self-regulation, mindfulness, body regulation. So you put your hands out in front of you, and you cross them on opposite sides. I see people already know this move. And you pretzel it towards your body, and you squeeze yourself, give yourself a big hug, and breathe into it. This is a body regulation mode, which we talk about dopamine release, right? We talk about serotonin, and this really does that. This helps youth when they're feeling strong feelings. Then you could actually switch sides, too, and squeeze again and breathe into that. It really helps you as an individual calm down anxiety, which I am definitely not feeling right now. The idea is to help youth empathize, develop mutual respect for each other, to build on equity and eliminate violence and racism. Integrated education plans for youth that may not have a current diagnosis, but that are exhibiting the symptoms of trauma in schools is actually something that we're looking at as far as a new practice. In addition to the collective impact approaches that our state has with adverse childhood experiences, and really looking at that equity, nonviolence, and anti-racism lenses in all that we do. With cultural identity and connection, best practices and suggestions for integrating with communities and providing them with assistance and changing some of their determinants of health is doing no further harm and starting from there. We want to reflect on cultural practices from your youth, things that you do that were incredibly helpful. We were talking earlier about singing and some of those things and how therapeutic that is. Think about some of the practices in your head of the cultural pieces that your family gave you, or your friends and family gave you, or your adopted family gave you, and how that supports you today. Cook Inlet Tribal Council has a Native Connections grant from the Substance Abuse Mental Health Services Administration to identify and address behavioral needs and Alaska Native youth needs through the gathering of Native American and Alaska Native work groups. This gives them an opportunity to grieve, to process emotions appropriately, to learn how to better integrate with cultural practices, and to integrate dancing and drumming with their Native elders. South Central Foundation is also integrating traditional Alaska Native approaches to outpatient settings, where the traditional westernized approaches to counseling may not be effective. These traditional approaches are seeming more effective for some people. So just last key implications for assisting communities. I'd like to address this by including some words from one of our partners, Clistel and Lemieux. She's Tlingit, and she's a suicide prevention coordinator at Cook Inlet Tribal Council. She says, just this weekend, I went fishing. She said, doing those sorts of healing processes, whatever you're doing, physical effects, it actually affects the spiritual. I joined a dance group because my community is singing like a prayer. It's like for Indigenous people. It's a way to lift your spirit up, bring yourself into balance, making that effort heal yourself. It's going to start affecting other people around you. She has 4 paddles on her hand, tattooed, and that represents emotional, spiritual, mental, and physical. Part of our approaches, right? We were mentioning Dr. Harrison. The canoe represents the community, and the person on the back is the elder. He's guiding the boat. The elder, adults, youth, they're trying to move forward and heal so they can get to where the sun is, to where the other Indigenous people are, so they can all start working together. Thank you. This is I've been told that the slides will be also on the AMCHP website, so you can actually look at some of these great resources. Thanks.
Thanks. Okay. So our next panelist is Tammy Boyd. Tammy is the Director of Health Policy and Legislative Affairs for the Black Women's Health Imperative. Tammy is an established healthcare executive with extensive experience in government relations, political compliance, and advocacy. Tammy has extensive experience in creating and executing federal legislative policy and facilitating outreach to members of the U.S. House of Representatives and the U.S. Senate. Tammy most recently served as a managing partner at TKB Global Strategies, where she successfully executed government affairs strategies through engagement of the House and Senate and federal agencies such as the FDA and the Center for Medicaid and Medicare Services. Welcome, Tammy.
Good morning. Thank you, Stacy, for that gracious introduction. As mentioned, I'm Tammy Boyd, and I oversee policy and legislative affairs for the Black Women's Health Imperative. The Black Women's Health Imperative is a national organization dedicated to improving the health and wellness of the nation's 21 million Black women and girls, physically, emotionally, and financially. One of our goals is to reframe the conversation that usually begins with Black women as the problem, and instead celebrate and normalize our rich lives, our value, and our worth. We have developed a publication called Index Us. Index Us uses data from Black women's health study, which nearly 60,000 Black women participated in for more than 20 years, and translates research and policy into a language that's easy to understand. It explores how Black women define health and wellness, creates a snapshot of healthy Black women by region, and examines critical policies that have shaped Black women's health. Predictive models of Black women most likely to adopt behaviors that support physical, emotional, and financial health. Programs and messages Black women and women of color can easily follow to improve their overall wellness. What we do know is that stress, racism, and sexism are strong predictors of our quality of life and ultimately life expectancy. Black women are less likely to receive a mental health diagnosis and mental health services. Only 1 in 3 African Americans who need mental health care receive it. The rate of illicit drug use among African Americans is slightly higher than the national average. Rate of opioid overdose among African Americans is less than half of that of non-Hispanic whites. However, the rate is increasing in the Black community. Compared with the general population, African Americans are less likely to be offered either evidence-based medication therapy or psychotherapy. We have also developed a Black women's policy agenda that outlines the key health issues impacting Black women. A lot of our policy work in the mental health space has been around implicit bias and its impact on health outcomes for Black women. Whether we are describing the maternal mortality crisis, where the rate is 3 to 4 times higher for Black women, or the opioid epidemic and pain treatment for African Americans. Pain and its treatment are strongly influenced by race and ethnicity, as well as by the social and economic conditions in which people work and live. The opioid epidemic looks different in the white community, as we know. It's more so around overdosing with prescription medicine for pain, whereas in the African American community, it's more around the illicit drug use. But African Americans have been less likely to be prescribed pain narcotics. Implicit bias, or a theory of that African Americans can tolerate pain better, is one of the reasons we may see less drugs being prescribed for pain. And we are also so I'm on the federal level. We are currently working, well, as you know, the opioid crisis is a very big issue on the federal level, and we worked closely in advocating for that legislation that passed in October. It's a bipartisan legislation. It authorized about $3.3 billion in spending over 10 years. And we are also watching very closely a second wave of opioid legislation that will come through, and advocating for Black women, women of color, and African Americans. Thank you.
Thank you. So now we're going to ask some of our experts some questions related to mental health and substance use. Jenny, I'm going to direct the first question to you. In your opinion, what are the most pressing issues the country faces right now regarding access to mental health and substance use disorders in marginalized communities?
I think we can start to no access or limited access due to wait lists, limited Medicaid reimbursement possibilities, provider shortages. I have a list. Geographic disparities. It's hard to get to mental health care. We end up sending people out of state for care at this point. Stigma to services. So once you go into services, especially if you have services in a smaller community, auntie, maybe you're a service provider. There's just not a service that's going to happen that way. And mistrust of governmentally funded services and programs.
Excellent, thank you. Tammy, we're going to address the next question to you. Given the national spotlight on opioid use, how can we as public health professionals best influence the national response to this crisis?
I think it's very important to hear from public health professionals, such as yourselves, to engage policymakers, let them know the different nuances that may be happening in your community. A lot of times in Washington, we sort of operate in a bubble. And so to hear what's happening in the particular states, geographically, in different communities, diverse communities, your input is, you're the folks on the front line. So your input is very critical, knowing those nuances.
Excellent, thank you. Sharice, I'm going to direct this one to you. By law, Title V programs must complete a statewide needs assessment every 5 years in order to receive their federal block grant funding. What advice do you have for Title V programs to gain authentic input from communities who are the end users of their services to help shape their programmatic work, especially in the area of mental health and substance use disorders?
I think a little bit of what I shared earlier today is a best practice model. It's really important to make sure that there is qualitative research being done, specifically with the populations that you're trying to serve. I think it's really important that the researchers need to reflect the population that you're trying to get this information from. I think more than not, we see far too much data come out that has not necessarily been led by a researcher of color that is supposed to inform the issues that are surrounding communities of color. So I definitely will lift that up. And then you want to make sure that you can apply what you have to really think about the folks that you're serving, as I said in my talking points earlier, as the experts of the lives that they are living, and to inform you on the best ways to serve them. Some of the work that we've done in Memphis and throughout the state of Tennessee that's been really helpful, if you're trying to think about maybe a step before the community, is the ways that Sister Reach has partnered with Vanderbilt Hospital and the University of Tennessee Knoxville Medical Center to try to figure out how to, best make sure that doctors get proper billing, for LARC insertion and extraction, as well as making sure that we are working together to make sure that Tennessee expands LARC access beyond just Morena, for example. I think we've also been able to make good strides with the Tennessee Department of Health. Sister Reach has been working along with them as partners, even looking at their presentations and information that they send out about like the tiered effectiveness of LARC, for example, making sure that it doesn't read coercive or it doesn't look as if one method is being preferenced over the other, but that the information is given to a patient in a comprehensive way, making sure that they have access to all of the information that they need to have about their body. So I think it's about being really intentional about the ways that we serve folks.
Excellent. And I'm going to address that question actually to our full panel. So with regards to opioids, enormous disparities exist among those affected by this crisis, with marginalized communities in both urban and rural areas being hit the hardest. How can we address these disparities through policy change? And maybe, Nzinga, we could start with you.
Sure. So piggybacking on what you said earlier, we know these underserved communities are less likely to be offered evidence-based interventions, including medication-assisted treatment. I think for substance use, all medical disorders, we get a conceptualization that this particular order is more biological than it is psychosocial, or this disorder is more psychosocial than it is biological. And so the mistake that we make, for example, for high blood pressure is you can just go to your primary care doctor and get antihypertensive medication and your blood pressure will be treated, underappreciating the need for psychosocial interventions. The substance abuse community really has underappreciated the need for biological interventions because the symptoms are behavioral, emotional, interpersonal. We think psychosocial interventions will be sufficient. And so what we're finding is that while private insurances have great reimbursement for MAT and access, and it's actually very profitable, so these MAT clinics are popping up everywhere, our underserved populations, rural and urban, are not getting that same access. And so I think in terms of policy considerations, I'll talk about stigma just a bit also. Before Suboxone came, we had methadone. So you can only prescribe methadone for substance use disorder from a methadone clinic. But any other physician can prescribe methadone just by a prescription for a pain disorder. That's purely stigma, because the risk of methadone is the risk of methadone. And so when we look at policy considerations, I think starting in medical school, we need to make sure that psychiatric and substance use and other psychiatric disorders, the education starts in medical school, the destigmatization starts in medical school, the evidence-based education starts in medical school, floats through every single specialty for all physicians, and then rolls actually into the policies that we have for prescribing, like, why do I need a special DEA number to prescribe Suboxone? Because stigma, right? And so and then I think also integrating, like you said, the medical voice, really I should say holding physicians to make us integrate our voice into the discussion, because so much of substance abuse policy happens outside the medical arena, and then medical is kind of a second thought. And we really need to be braiding our funding and our education and our policies so that it is truly biopsychosocial, cultural, spiritual, political.
Excellent. Anyone else want to respond to that?
I also think that it's important to make sure that the little fights along the way, which is for us a huge fight in the state of Tennessee, like healthcare reform. Tennessee didn't expand Medicaid, right? So we can't expand behavioral health clinics across the state. When the fetal assault law happened in Tennessee, we have 117 clinics across the entire state. Only 8 of them are in Memphis, and only 1 of those have beds, and it's only 10 beds to be able to put a woman and have a woman in, right? So we can't have a conversation about how we're gonna, curb something without even at the very baseline making sure that the very practical needs of our patients or your patients are a priority.
Excellent. Okay. I'm assuming we're gonna get the hook at some point. I'm just watching this clock here, so I'm assuming that we're okay. All right. Okay, this I'm going to address to all of you. So with the surge in opioid use by reproductive age women and the rise in babies born with neonatal abstinence syndrome, there's been a movement towards criminalization of pregnant drug-using women. For example, some states have mandatory reporting of pregnant women suspected of illicit drug use, and others require birthing hospitals to drug test women at the time of delivery. As MCH advocates, how can we counter these punitive approaches that push women away from services designed to improve pregnancy outcomes? Who would like to take a crack at that one?
Right, that's my thing. Okay, so this is it's your responsibility to hold lawmakers accountable. It's your responsibility. There's no way that the fetal assault law should have been able to become law. And I recognize, right? I recognize that every medical association in the United States were on our side around this law being harmful, except for the Tennessee Managed Care Association, the Tennessee Medical Association. It was because of the Tennessee Medical Association that former Governor Haslam signed the bill into law with just ignoring everybody else and every other statement that was made by every other medical association. So I guess in my comments, I was so angry. I'm angry now because there's a new bill on the floor in the House, right, where they're trying to bring it back, even though it's been proven to be ineffective. Even though our research now, which will be released Thursday, but research from other folks in the state show that the law was ineffective, and the rates of folks using opioids hasn't decreased. Let's be clear. So either we're truly, interested in, well, let me say this, you guys have to become advocates. We need you on the Hill. And if you don't have the capacity, because I recognize what that looks like, then we have to have AMCHP and these medical associations to have lobbyists on the Hill on your behalf, speaking to legislators, holding them accountable. And if there's money to put in the legislator's pocket to vote a certain way, then that money needs to be voting against these types of policies that put women in prison, take away their children, with no plan of action to ever get them back, with no real method in place for them to truly become clean. A 28-day detox program, this from a child of a heroin addict all my life, is insufficient for my father. A 28-day detox program, basically, according to his doctor, would make his heart explode, right? And so it doesn't work. And so then why would that actually be legislated as a real program? And then why would the public health community, as the child of the drug addict, right, or the drug user, why would you all allow it to happen? So we've got to be able to move this work, and we've got to be able to come and bring all of our tools from the toolbox together. If you can't do it, there are policy folks who can do it, but it's got to come from your community. I think that's really important. It's one thing for Sister Reach, it's one thing for Planned Parenthood, it's one thing for HIV advocates to say these things, it's another thing for doctors to get on the Hill. It's another thing that matters. So we really want you all to consider what that looks like, or this will not change. It won't change.
I don't think anybody needs to follow that up with any comments.
All right, I'm going to ask a Medicaid question now. So Medicaid's been described as the most effective tool we have to address mental health and substance use in low-income women. Yet Medicaid is usually the biggest budget item in a state budget, and there are many competing demands for Medicaid dollars. How can we make mental health and substance use disorders in women a top priority for our Medicaid colleagues and our state legislators? Nzinga, would you like to take a crack at that?
Sure, I can take a stab at that. So I agree, Medicaid could be the biggest tool that we have for addressing mental health and substance use disorders in our lower income populations, but because the way reimbursement is structured, it is not. And so, as I mentioned earlier, when we look at the natural history of disease of substance use disorders, like you said, for your dad, no, a 28-day detox does not sufficiently treat a substance use disorder, just like a 28-day course of chemo does not sufficiently treat breast cancer, right? Or if you have end-stage renal disease, we give you 2 weeks of dialysis and say, good luck living. Like, we don't do that, right? And so it comes back to stigma. Again, I think the way we talk to our legislators, because it is about money, we know that prevention and early intervention cost less than emergency intervention. At this point, our substance abuse services are concentrated in the emergency department, and that makes them extremely expensive. And so if we can generate the data and do the research that shows, we can actually meet the aims of the triple aim. Like, we can decrease the per capita cost of treating substance use and other mental health disorders. We can improve the customer experience, the customer being not just the index person with the disorder, but the entire community that they could be contributing to. And we can improve the clinical outcomes, actually. So a concept that I always like to push is like, focus on the outcome, not the obstacle. So the substance use disorder or the mental health disorder is the obstacle. The outcome that we desire is that folks lead healthy, meaningful lives and create healthy, meaningful communities that lead to healthy, meaningful, universe, right? And so if we focus on that outcome and look longer term instead of just this budget cycle, this budget cycle, this budget cycle, substance abuse costs a lot, substance abuse costs a lot, focus on the outcome, the goal, and start generating policy towards that larger goal. And then we would move away from fee-for-service. We would move away from bed day reimbursement. It would be like end-stage renal disease where Medicaid pays for it, period. Right? And so if you're in the acute phase of your mental health or substance use disorder, you have access to the services you need. If you're in recovery, we've engaged you to reach back and contribute, right? And so I think just helping our legislators move the vision from the current budget cycle obstacle to that longer term outcome is the work that we need to do.
Excellent.
And I was just going to add, and just even to add in terms of your state legislators, you mentioned Capitol Hill. I mean, there's the federal level, but then there's and a lot of folks think, I mean, as public health officials, you may feel like you have requirements and you can't necessarily go and talk to your legislators, but you can advocate from an expertise or sort of what you're seeing in your community. I mean, that is extremely beneficial to members of Congress, to state representatives. So definitely encourage, piggyback what everyone said, in advocating to your local representative or your member of Congress.
Mm-hmm. Mm-hmm. Excellent. Okay, I have one last question. I know we're quickly running out of time here. I wanted to ask a question about behavioral health integration as a delivery system technique. So linking mental health and substance use disorders with primary care, which is the intent of integration, it has broad support, but it's been slow to catch on in many communities. What do you attribute to this, and how can we overcome some of this? I'd like to take a crack at that.
Can I just change the conversation slightly? Because I
Sure.
feel like we keep going back to services, and I'm not necessarily sure that's where we all need to focus everything. We're talking about moonshot and making changes faster and being in a hurry. Then we need to invest in programs that take time, not defunding education and being able to have conversations within our community. Don't do another needs assessment without talking to the people that you're representing. Children with special health care needs, youth, women that might be experiencing maternal death, communities of color. Those are the people that are suffering the most. And if we keep just focusing on services, we're not going to do public health. We need to be way back over here. So, I mean, if we're going to spend the last 20 seconds, I think that's where we should talk.
How about that?
Agree.
Yep.
I would drop your mic, but it's tape.
We have about 10 seconds.
And so do it
Sum
now.
that
I
up.
mean, drop the mic on that. Absolutely.
that's
Change the outcome. Focus on the goal.
Excellent, excellent.
That's right.
Great insight, great thought.
Thank you.
Really appreciate it. Can we give our appreciation to our panelists?